Let me act as a, acting moderator. And most respectfully, I would like to call the chairperson, Dr. Radha Ramanan sir, to the dais. And the co-chairperson, I'm sorry, I cannot see her, and neither the convener. So I would like to call the co-convener, Dr. J.J. Agarwal sir, also to the dais, please. And I believe the real moderator is on the way. And now, I over to them for the rest of the deliberations.
Good morning. I am Dr. Radharaman. I am from Kerala. Along with me, I think now at present it is only Dr. Jayagopal Agarwal is here. He is from Patna. I expect that our co-chairperson Dr. Vinita Gupta, convener Dr. Rajendra Prasad, and our moderator Dr. Deepak Misra also will join with him. So our section is from 10 to 10:55. We covers actually from different specialties in this section. This is a golden words of comprehensive ophthalmology, section 3. How many presenters are here? I think
Three presentations. Yeah? 3 presenters are here. I'm here. Dr. Inder Mohan, Dr. is here. Dr. Sudipta Mitra is here. Dr. Shamya Shashi? No, she's not there, I think.
So,
and
who wanted to start? Okay.
I'm already there.
Okay, you'll start.
Thank you so much, sir. Please project my slides.
Dr. Soni Sinha. Dr. Soni Sinha will be talking about the pregnancy and the eye. It's a comprehensive insight.
Thank you, sirs, and good morning, and welcome to this program. The objectives of this would be a myriad, look at pregnancy and the eye. And the effects of physiological changes include the effects on the lid, which are chloasma, spinal angiomas, ptosis, and hypsomagma in conjunctiva, which of course regresses. Dry eye gets aggravated due to differences in the hormones and the cytokines that occur, as well as dehydration due to hyperemesis, which is enhanced by contact lens use and therefore is best avoided. Cornea sensitivity decreases while thickness and curvature increase. The Krukenberg spindles may occur. Accommodative insufficiency and paralysis and myopic shift make refraction during this time very tricky. Intraocular pressure decreases by 2 to 3 millimeters, a 20% reduction in the third trimester due to increased UV scleral flow and decreased episcleral venous pressure. Choroidal thickness increases maximally in the second trimester. And on pre-existing eye disorders, the uveitis goes waxing and waning, but in general, the need for immunosuppressants reduces, especially in sarcoidosis or spondyloarthropathies, while postpartum endogenous candida endophthalmitis has been reported. Choroidal hemangiomas may show rapid growth, while some can regress postpartum. Ocular toxoplasmosis can reactivate, and torch infection monitoring is very important, and treatment. Retinitis pigmentosa can show progression. Pregnancy is an independent risk factor for development and progression of diabetic retinopathy in IDDM, and 2 to 5% diabetics are there before conception, while gestational diabetic retinopathy rapidly progresses and regresses once pregnancy is terminated. The progression factors are the usual, while monitoring is needed without a diabetic retinopathy 3 to 12 monthly, and in severe NPDR it may be needed monthly or even 3 monthly up to a year after delivery. Macular edema may occur, which may regress after delivery. The management is the same as this, and laser and surgery can be done as indicated. The Graves' disease is the most common cause of hyperthyroidism, which aggravates in the first trimester and undergoes a waxing and waning course. Drug of choice is propylthiouracil. Glaucoma, both in ocular hypertensives as well as the open-angle glaucoma, is reported to improve. Migraine attacks, the frequency may increase or decrease during pregnancy. With pregnancy-related diseases, there can be preeclampsia and eclampsia with different etiology, and it can lead to ocular symptoms, a myriad of them. And ultimately, we can see some stages of retinal pathology, as in the spastic stage, angiospasm starts from the superior nasal retina, or followed by the sclerotic state, and ultimately a frank hypertensive retinopathy, which may have all the stigmata of hypertensive retinopathy, including serous retinal detachment. So this retinal detachment is more found in eclamptics than pre-eclamptics due to choroidal ischemia. And the HELP syndrome may also involve the eye with bilateral serous retinal detachment, which is hemorrhage sometimes. There can also be cortical blindness and venous occlusion in preeclampsia and eclampsia. TTP can result in serous RD as well as optic disc edema. Antiphospholipid antibody syndrome can cause conjunctival telangiectasias and microaneurysms, episcleritis, limbal filamentous keratitis, and neuritis, while posterior segment findings include vitritis, retinal detachment, posterior scleritis, various vascular occlusions, tortuosity, hemorrhage, and soft exudates. There can also be CSR with fibrinous retinal exudation, while as neuro-ophthalmologic changes can occur with including sinus thrombosis of the superior sagittal lateral and cavernous sinus with Krauss sign, very pathognomonic. There can also be posterior pituitary enlargement leading to various types of visual field defects. The macroprolactinomas can become symptomatic and increase the risk of miscarriage and prematurity, and field testing and even surgical intervention may be required. Meningiomas can show accelerated growth due to receptors. Benign intracranial hypertension becomes very difficult to treat because of the adverse effects of ketosis on the fetus, because of low birth weight and spontaneous abortion that can occur due to treatment, and electrolytes need to be monitored very closely. Optic neuritis and neuropathy may be there because of relapse in multiple sclerosis, while hyperemesis can lead to vitamin B deficiency with transient nerve palsies because of polyneuritis. Apart from this, about medications, we have some drugs for glaucoma, and it's important to have preconception counseling, and brimonidine is the drug of choice for first and second trimesters along with bitoxolol. And in the second trimester, we might have oral carbonic anhydrase inhibitors added because prostaglandins can cause premature labor. In the third trimester, to prevent fetal apnea near term, it's important to switch to topical carbonic anhydrase inhibitors, while as postpartum, carbonic anhydrase inhibitors and bitoxolol can be used, while laser can be opted for at any stage, but surgery is best in the second trimester. About the anesthetics, the proparacaine and bupivacaine are not really recommended because of bradycardia in the fetus. Fluorescent dye is yet to be avoided, especially in the first trimester. Antibiotics like chloramphenicol, neomycin, and tetracycline are contraindicated because of adverse effects, while systemic tobramycin also is to be avoided, although topical tobramycin can be used. About antiallergics, antihistaminics are best avoided in this condition. About the anti-inflammatory drugs, prednisolone is better to be used because it crosses the placenta somewhat less than dexamethasone, and interferons are safe, while as all other immunomodulators or other drugs may be embryotoxic and fetotoxic and are best not to be used. The treatment of neovascularization carries the risk of miscarriages due to defective placental and fetal vasculature if anti-VEGFs are used or PDT is used. So a risk-benefit ratio has to be weighed, and the complete antibody bevacizumab is to be preferred as it does not cross the placenta, while as vertiporfin is a category C drug known to cause an or microphthalmia, and therefore not to be used. So to conclude, the awareness of physiological and pathological conditions is important for ocular health of pregnant women. The strategic response to patients with ocular diseases prevents possible risks to mother and baby, and ophthalmic medications with potential adverse effects on the mother and baby need to be prescribed with extreme caution. For paucity of time, I have eliminated the complications instituted with labor and delivery, like Sheehan syndrome, like post-traumatic stress disorder, etc. Thank you so much for your kind attention.
Thank you, Dr. Soni Simha. It's a very, very extensive subject. It is very difficult to cover it in
7 minutes.
7 minutes.
Totally, sir.
But most of the time it is the treatment which is really difficult in pregnancy, because with the introduction of this Google and all, if anything happens to the child, they are going to sue us.
Absolutely.
So that's a big, sometimes it won't be related to this thing, but some reports, they can find it from somewhere. So it is very important to have explained everything to the patient. See, like if it's a glaucoma patient,
Absolutely. The risk-benefit ratio has to be weighed and counseled, properly counseled at every stage, sir. Any intervention before that, we have to counsel the patient.
so like brimonidine also is a questionable thing because
Yes.
it comes in the group B, but there are so many complications reported
Absolutely.
after that. So it's a
Absolutely.
real question, which medicine, what, rather than this, which medicine you prefer usually?
Sir, as of now, we will at least be supported by the written texts and published literature, so I do go with brimonidine, knowing, counseling the patient as to the risks and the benefits.
If it is not controlled with
And
the
then carbonic anhydrase inhibitors.
Okay.
That's most-
Dr. Soni, just tell me that your presentation is very extensive, but as a general practitioner, what is your suggestion to go what type of examination should be done for the pregnant patient?
Sir, I think because antenatal care is being taken up by the gynecologist, we should be counseling gynecologists to send the patient to us every time they're doing an antenatal checkup. Because if there's any sort of complaint even before the pregnancy or there's a diabetic patient, all of them should be sending them to us. We do counsel, in my institution, I have counseled my gynecologists and of the obstetricians to this regard, sir.
And that is the part of the gynecologist.
Yes.
We are sending it to you.
And then,
But if in outpatient department, any pregnant patient comes to you, as an ophthalmologist, what should you examine at that moment? Because
We
there are
have to
many,
do-
you have to elaborate.
we have to do a complete history, sir, taking. Then we have to, of course, do a comprehensive eye examination. I don't think that we can leave out even mydriasis. So we have to dilate the patient, we have to see the anterior and posterior segments quite thoroughly. And after that, if needed, we have to go in for investigation, non-invasive ones like OCT. And if at all fluorescent angiography is indicated, avoid it in the first trimester. But if it's a must, then we have to go in for that also. And then newer modalities like Octa coming in, maybe that would be a better modality in being non-invasive for the retinopathies and things like that.
Okay.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, Dr. Soni. Dr. Sudipta Mitra is here. Okay, thank you. She will be talking about indirect effect of lengthy pandemic on ocular diseases, cases in which paradise was lost. I think this is another real trouble in this these days. I think this is still continuing, no? Okay.
Good morning, everybody, and hearty welcome, respected chairpersons and my dear friends. Can you just start my slide video, please? Yeah. Just stop it there. It is indeed a pleasure to be here. This is my first visit to Patna, and in the first MidCon conference of AIOC. So I'm really grateful to AIOC Scientific Committee for this chance. Now, the indirect effect of the pandemic and how we lost our paradise in two cases. I have no financial interest in anything that I'm going to talk. Loss in pandemic, why and how. COVID-19 pandemic had staggered eye care for 2 years. Slowly and steadily the cases emerged. All of us might have experienced, which did not report earlier, either due to the difficulty in coming and the diseases worsened and progressed. We report 2 such cases where gross vision loss was there, either due to the disease or the treatment protocol or due to delayed reporting. It was a 63-year-old lady with bilateral pseudophakia, which ended up with uveitis in right eye. The past history, she had bilaterally been operated in 2018, May, with best corrected visual acuity of 6.6, N6 in both eyes. A phaco was done. She was a cancer survivor, but all her vitals were stable. She was not on any more treatment. Investigations and checkup by oncologists did not suggest anything. She had a tooth problem. The first episode where in December 2019, she reported blurring of vision in right eye as the main symptom on day 2 of the disease. Her intraocular pressure was normal, posterior segment was normal. She was treated with prednisolone acetate 6 times with tapering over 2 weeks, and she got normal. And she was followed up from December 2019. And we did not receive any phone calls from her. Now she came in April 2020 when she called up and said that she had similar blurring of vision in right eye as in 19 December. Due to restrictions of travel, she did not come. She was 80 kilometers away from Kolkata, so she was put on prednisolone acetate 6 times a day. She complained of sudden aggravation of toothache, which was scheduled to be removed. But then it did not happen due to the COVID-19 pandemic. On day 2, after consultation on phone, no video, she reported redness and pain, and it worsened, and she was given analgesics, etc. to manage. Finally, she turned on day 5. And this was the character of the eye that we saw immediately. Was anterior chamber was nearly flat. There was severe iridocyclitis with exudates in the iris. The pupil area was blocked with membranous exudates. CCC, prominent iris markings were obliterated. High pressure, 59 millimeter with occlusure pupillae with exudates. And she was in severe pain. So we had to do something. We gave oral acetazolamide tablets, IV mannitol, analgesics, anti-glaucoma, topical steroids. Half an hour, it was 56. So we had to do something. USG suggested nothing, like supracortical effusion or hemorrhage. PI or a peripheral iridotomy could be done, but it was nearly flat. So we thought to find out one area where we could do a pupillotomy. And then after taking her consent, we tried to do a pupillotomy in the center because the periphery was nearly flat. So trying to save the eye with a contact lens, we used the first shot. Immediately there was a gush of fluid, and slowly the AC formed, and we used furthermost shots and enlarged it. The membrane retracted, there was relief of pain, tapering dose of steroids were started, and she went back. For 3 months she did well, but she lost to follow-up. Admitted with COVID in 2021, she developed post-COVID complications, diabetes. She reported only in August 2021 with recurrent episodes of pain in right eye. She said she used acetazolamide tablets, anti-glaucoma medications, steroids, and she was restricted indoors, morbidities, restriction in travel. Vision right eye then was only hand movement, IRP 58, and she had neovascularization of the iris. I'm not sure, but then can you just stop the video one sec? The sound is, can you just stop? It's not working here. Yeah. So I just wanted to show this picture. Please don't start the video, I stopped it. Yeah. So this was the picture that this is the neovascularization of the iris that we noted. And she, because of the mismanaged episodes of uveitis and secondary glaucoma with ischemia, this led to nearly normal functional eye to become a severely damaged eye. And she also had inferior band keratopathy, maybe because of the consequence of mismanaged uveitis. So what to do next? It was beyond my control. I referred to a glaucoma specialist, a retina specialist. She received anti-VEGF, if you can see from here, and eccentrics. I have no financial interest in anything. And anterior cryopexy was done because of this neovascularization of the iris. Of course, the neovessels regressed, but vision did not restore to 6.6. So paradise was lost in this case. This is the case 2. Again, a 63-year-old female, which had best corrected vision acuity of 618 when she reported it to us in February 2022, left eye counting fingers. Now, this patient also had undergone cataract surgery in November 2019 with 6.6 N6 vision, and if you can see, the OCT and the fundus were absolutely normal in both eyes in 2019. This patient had COVID in April 2021, July 2021, hospitalized, bedridden. She could not come to us. 2 weeks to report. Her fasting blood sugar was normal when she came, and this was the picture in her right eye, a BRVO. 3 weeks of hospitalization, she received remdesivir, antibiotics, lots of them, anticoagulants, steroids, high flow oxygen, anything could have caused the bleeding, and OCT, which we repeated, had in one occasion showed 599 thickness of the macula on February 2022. We did the left eye to restore a bit of her vision. and she was given this she was advised anti-VEGF injection, but she could not take it because of her waxing and waning of the comorbidities post-COVID. She received it in May 2022. This is the picture. So all this, which had a normal OCT, ended up in something like this. After ranibizumab injection, we found there was a bit of CNVM. The edema had reduced. She is still under our treatment. Now, in this case also, what we presumed, the literature says that COVID-19 virus causes both anterior and posterior segment diseases. She was anticoagulants, and remdesivir we know was given for life-saving, but it has some episodes of bleeding. And again, she had received lots of steroids, lots of antibiotics. So all this, and then she could not report to us at the correct time, which she said was from the start of her COVID, which might have all and ended up in this case of lost eye. Thank you for patient hearing.
It's a good presentation, madam.
Thank you, sir.
Actually, you have just represented 2 cases.
Pardon?
You have just represented 2 cases.
Yeah.
Really, there will be hundreds of cases
of
like
cases,
this. Mostly.
But, one thing I want to ask you, why you correlate with the COVID?
Yeah, because these people could not come to us because this case was saved. This patient was saved once with pupillotomy, the first case. If she had come to me earlier, then this NVI which had
I
developed
want
in
to
her
ask
IDP.
you, in general population also you can get to
Yes, sir, but that
this
prolonged
few number of
nature.
cases.
I am not relating to COVID disease itself. I am relating to the lack of communication that she had with us. Physical communication that she had, and she could not be treated also because of that. She could not reach us. It's not because of the disease, it's because of the prolonged nature of the pandemic that we are still, in fact, now patients can still travel. Actually, this patient was in Digha when she reported to me. So she did not get, she had to get a special permission from the DM to come to me. That took 3-4 days.
That means a lack of treatment has
Because of the prolonged nature of the pandemic.
lost paradise, isn't it?
Yeah. Yes, sir. That is what I wanted to express.
I think this is mainly happened with the glaucoma patients,
Yes.
uveitis patients,
Yes.
and retinal patients, because it's not directly due to the COVID. Because only few patients having COVID
Yeah,
problems.
that was
but
the theme, sir. I said
Yeah,
indirect
this is
effect
the
of
main-
the COVID.
This is happened in so many cases. It's
Yes.
actually well controlled cases lost because some of the patients even were not able to get some of the medicines because it was not
Correct,
available
correct.
to
It
their
was not
places,
available.
because it was only opened few medical shops in the nearby. They could not travel it and they could not manage it. So it was a real trouble. You just showed a
Yeah, I
representation
just
of
tip of the iceberg. I just represented.
just showed how it is. Actually, even cataract is not that problematic because some patients had a very mature cataract and
Brown cataract.
some patients had even lens-induced glaucoma also.
Glaucoma, yes.
But other cases, like so many patients were lost glaucoma treatment and retinal treatment because
They could
diabetic
not continue,
retinopathy,
could not come to us.
diabetic retinopathy
Diabetic retinopathy.
patients
And many of them,
lost.
sir, like this patient, the first patient, did not have glaucoma, did not have diabetes. So post-COVID, she developed diabetes. Due to that, her uveitis further increased and everything went haywire. So we could not restore the eye to what she actually had. That was the painful part of it.
What is the situation in Calcutta now? They are all coming.
Sir, regarding COVID,
Yeah.
COVID, we are having stray cases, of course, but none of them are that lethal.
No, I am asking in the other aspect. See, your old patients are all almost 100% coming back to treatment.
Yes, most
Yes,
of them.
that's good.
They have come back to treatment and travel restrictions are not there. In fact, we've all given up on masks except for in the hospitals.
That is happening everywhere in India.
So people has actually tried to, is trying to forget COVID.
No, sir, we have restarted using masks.
Yeah,
That's in the
we also
Fourth wave coming up, now we have
we also start.
We are expecting, ma'am, we are expecting after this Ganga Sagar that we are having, we are expecting a flood, but then that we are expecting as doctors. General people.
precautions, because we are really jammed in, being in a government
Yeah.
hospital, we are jammed in by
Yeah.
patients, so we are now wearing our masks.
So one good advantage of this mask wearing is not only for the COVID.
Yes,
Actually,
coming to
then
diseases.
the other specialty people start telling. One of my friend was telling, say, we should stop using mask because I am not having any patient now. So these COVID years, actually all respiratory problem, regular patients having problems, they actually had a reduction in their diseases. So
Yes,
it has
very
gotten,
much.
we are discussing about our ophthalmic more problems and all. Some specialty having a reverse effect because of the COVID.
That's
So,
true, sir, because traveling with a mask gives you much, your throat is much better. So, pollution much
pollution.
less. So,
So
One,
morning I was traveling with a mask because when I was going out, when you are using the mask, you will have a this your
runny
lungs
nose
and
and
all.
throat,
Because in Kerala, we are coming from Kerala, we are not that used to this
this
type
cold,
of climates actually.
climate.
So we don't have a temperature below 22 or something in any time in a year. So I think next year you all be coming to Cochin for the All India.
Dr. Mitra, just I
Yes,
want to
yes, sir.
mention one
Yes,
thing.
sir.
2 days back, I got a literature from America that new variants of COVID
Yeah.
is directly affecting the brain and the
Oh.
brain.
There are some reports like
Yes.
brain damages. It's not clarified yet,
Yes.
but it's a very, very
How is it
dangerous one.
Yes,
affecting, sir?
recent variants of in the China or even in the America, it is directly affecting the brain and the
Optic
eye.
nerve, they're affecting nerve
Ah, yes.
It's not confirmed reports, but they started the study.
study. Okay.
Some BXX5 or something.
And it is written that it is directly affecting the brain and
It's a dangerous.
the eye. Yeah.
No, it's
Somewhere
the
they'll
report
find-
showing that it is affecting the brain.
Brain.
So following that, it comes to the, because optic nerve is directly to that
Yeah,
one. But no definite report. They have started studying the reports because only the initial stage of that one.
It is a very
We don't know.
dangerous scenario
If
then.
it comes to the India, then it will be real trouble. Thank you.
sir.
sir.
Thank you so much.
So, yeah. Okay.
Good morning. This is a potpourri type of session, and my topic is tips for avoiding complication in SSICUs. One of the most commonly used surgical technique, and not only in developing countries, it is gaining popularity in other countries also. And the complications in SSICs can be caused by the procedure itself, the disease itself, which is prone to complications, and maybe unrelated to this thing. But whenever there is a complication, keep calm. It's just a complication. Let it go. Precautions common for all surgeries, where we have to take precautions, otherwise that can lead to the complications. So clean the skin around the eye with povidone iodine, which is a very well postulated hypothesis, and proper hand washing, use of sterile instruments, subconjunctival injections of the antibiotics, and intracameral antibiotics used in high-risk cases that can avoid so many complications. We should not forget these common complications, these common precautions. And tips for a neosurgeon. Proper visualization is the key. Scleral exposure has to be the best. For beginners, yes, bridle sutures should be placed, though in expert they are not using this bridle suture. For SSIs, globe has to be firm, otherwise tunnel may be improper. And try to make the astigmatic neutral incision placement. Sweep the tunnel properly in all directions before completing the tunnel or before puncturing it. No tilting of crescent blade or keratome, otherwise scleral cut or tilted cut in the cornea may happen, which may lead to the leaky wound later on. Correct corneoscleral incision, that is at least 1 to 2 millimeter has to be inside the clear cornea, and that will only lead to the self-sealing wound. Yes, recently there was an article in the IJO also that we can have an idea how this tunnel can be precisely taken by injecting blue dye into the tunnel. Appropriate scleral cauterization that can lead to avoidance of the hyphema. For a beginners, sharp tunnel instrument should be used. Blunt one can cause decimal stripping. We should stabilize the sclera with tooth forceps, and otherwise, and we should not hold this tunnel lip. Depth of the half thickness scleral tunnel incision to be such that the blade should not be too clearly visible. Otherwise, that will lead to the buttonholing of the wound. So we can see this blade, and if it is too superficial or too deep, that will again lead to the complications. If the crescent is not visible, that is too inside the sclera, and that will lead to the premature entry. And premature entry will further lead to the surgical complications of the iris itself. While making tunnel constructions, length has to be proper size, and the length depends upon the size and density of the nucleus. Soft cataract is there, small tunnel can be taken care of. If the hard nucleus is there, the tunnel has to be large. Depth of the tunnel matters. Very deep incision will lead to the premature entry, as already told, and superficial entry will lead to the buttonholing. The placement has, if it is too anterior, the wound will be non-sealing and leaky. So the ultimate aim is tunnel has to be self-sealed, and if not sure, don't hesitate in applying 1 to 2 sutures, but don't leave the leaky tunnel. And second step is opening of the anterior capsule or capsulotomy or capsulorhexis. Best is CCC if you can make it. For beginners, yes, it is difficult, or can do linear capsulotomy. So failing to complete the anterior capsulotomy or making a too small CCC can lead to the trouble. So early recognition of this thing is very important. Pulling residual anterior capsular tags can cause the posterior capsular to rupture. PCR can happen. So that will again lead to so many uncounted problems. Next is nucleus removal. Problem with the different SICS technique of nucleus removal are mainly related to the size of the tunnel and the proximity of the nucleus to the corneal endothelium. If the inner tunnel opening is too small, so we have to check that also before nucleus removal with the visco cannula or your iris spatula also. So we should mobilize the nucleus before lifting it into the anterior chamber, or anterior, the accidental contact with the nucleus and the corneal endothelium, that should be at all avoided. Otherwise, that will again lead to the corneal problems. So to avoid corneal problems, we have to have sufficient visco, and we should be, aware that all these instruments, they should be kept away from the cornea. Otherwise, that again will lead to the trauma to the cornea and multiple problems. So generally pulling the bridle suture makes nuclear delivery through the tunnel easier. So that should be taken care of. And next step is removal of the cortex. Main thing is subincisional cortex. That is the problematic thing for the beginners. And decimal detachment should be taken care of. Flow of fluid, that should be away from the endothelium side and towards the iris plane. We should always have a watch on the PCR. So proper cortex removal is the key in this thing. Few steps like decimal detachment can occur at any step. Treatment remains the standard one. If you face intraoperative myosis, these days these injections are available. If the hyphema is there, if it is small, can be left as such. If it is aerodialysis, that should be repaired. If it is zonular dialysis, we can use the CTR or ring as available. If it is expulsive hemorrhage, yes, it is very, very rare, but you know, if you have given anesthesia and all that, standard protocol has to be taken care of. And in PCR, again, standard protocol depending upon the extent. Immediate postoperative complications, that is wound adhesions. Yes, if it is large gap, again, if you don't hesitate in applying sutures, you will save the money, you will save many tensions. Corneal stria or edema managed depending on the degree. And postoperative IRT, so that the cycloplegic should be used. Secondary glaucoma, of course, medicines can be taken care of. Top tips are be patient, and be patient. Recognition is the key. You have to apply judgment, how to manage it, and that depends upon your skill and knowledge. Thank you very much.
It's a very good presentation. It's the most common surgery going on, not only in India, I think, all over the world now. So people will be starting with most of the time with the 6 years. So it is a starting. Which incision you will advise for the beginners, as a temporal or a superior?
Superior.
Superior for the.
For the beginners, I think they should be at comfort. Temporal, I don't think so. Beginners should go.
So the question why I ask is, some of the people who start on superior, they hesitate to shift to temporal later. So I think some of the institutions, they tell us, just start on the superior, then immediately convert it into temporal. So what do you think that?
Dr. Deepak Mishra would.
No, it depends upon the pre-existing astigmatism. If it is at 180 degrees plus, then you can go for the.
That is right, sir. But
temporal.
the main thing is for the beginners.
Yes.
For beginners, I think astigmatism, yes, it is the key. But ultimate outcome and the morning after the surgery and the confidence of the surgeon, which is a beginner one, if you leaky wound and all that, the problem is there. He will be hesitating in doing second surgery.
And one thing also that during capsulorhexis, you have to use copious amount of viscoelastic.
Yes, of course.
So that the
Yes.
lens will be at least plain or in the concave.
Yes, sir.
Otherwise, it will run, capsulorhexis will run out.
I think Dr. Deepak Mishra also joined. Welcome
Yes.
welcome Deepak Mishra to this thing.
Yes, sir. Yes, sir.
Only Tejas is there, so we have enough time.
Yes.
There is no problem to go with temporal incision. No problem.
Only thing advantage needed for beginner is the proper depth and the size of the tunnel, not the placement. What I suggest for everyone that at least try to make tunnel at a proper depth, neither superficial nor deep,
Nor deep.
and a good size, because most of the time you have seen even in the expert hands too, the size is either slightly less or more, and most of the complication like iris prolapse and other thing happen because of the size. So if anyone which is at beginning stage able to maintain the depth and the size of the astigmatum, that means that incision, that is much more enough as compared to whatever the recent thing, different types of incision or the site of incision. These are, I can say, at the secondary level. Means you have learned this ICS, now you want to modify yourself to reduce the astigmatism or more and more. That is a different thing. But for beginner topic,
Let's see.
दूसरा खोल देता हूँ.
Dr. Soumya is here. I think no.
So I will let's make it very interactive. What is the importance of an intact posterior capsule? What is the importance of an intact posterior capsule?
Anyone from audience?
Anyone? What is the importance of an intact posterior capsule? Why did we switch from intracapsular to extracapsular and then to phacoemulsification? We needed an intact posterior capsule.
Are the-
Intact posterior capsule is very important for the retinal pathology.
Yes.
If there is any rent in the posterior capsule, that means you are going for the adverse to the retinal.
Absolutely. Then after leaving a very nice posterior capsule and in the bag IOL,
Yes.
why should we do a hole in the posterior capsule? That is my talk. You should not do a YAG capsulotomy of the posterior capsule, but you should rather go ahead and fish out the pearls from the bag. That is my talk today. 1 minute? Okay. So this method I have been advocating since now about 10 years, somehow not very popular. It is a bit complex and it is very difficult also sometimes to convince the patient कि जो चीज़ 2 सेकंड में हो जाती है with a YAG capsulotomy, why should we undergo a complete surgery? But well, it all started with certain very specific patients like a high myope, a patient having a history of RD or a CME in the other eye. So on all these patients, we thought it is very, very dangerous to do a posterior capsulotomy. And so we thought of why not go ahead and clean the posterior capsule like we did during the surgery.
Do you want to say that during the IOL incision, then at that time also you can go for the posterior capsule?
No, I'm talking about posterior capsule. This is the Elschnick's pulse which we want to remove post-surgery. So this is a patient, right, who is presenting to you. In fact, this is a femto cataract patient, a young gentleman from the very famous Adani group who is a vice president there. He's only 40 and a high myope and only one-eyed patient. So I didn't want to actually do a posterior capsulotomy. And as you can see, in spite of a very nicely covered posterior capsule all along the IOL, we need to get a cleavage, right? And that is what I'm trying to do. Now, after I get hold of this cleavage, I'm going to try and create some space beneath the IOL. And then we are actually trying to manually remove all the Elschnick pulse from the equator as well as from the posterior capsule. In this high magnification, it does look a bit scary, but trust me, it is not at all scary. You can very easily do it. See, you have to understand, why did the posterior capsular opacification happen? That because there was some space behind the IOL, right? So there was already a potential space behind the IOL, so why not exploit it, right? And so this is what I succeeded. And this is a manual aspiration, very simple. It's a 27 gauge cannula, a 2 cc syringe. The chamber is filled with viscoelastic, so you just need to keep on aspirating. Yes, you might need to replenish the antechamber with more viscoelastic. Sorry, but Patna cold has really caught me on.
Water.
Yeah.
Before water.
No, I'm okay. Thank you. Chalega, abhi nahi chale. Yes. Yes, it takes me as long as time as a cataract surgery, probably sometimes even more, because we have to be very careful. But the result, the end of the surgery is going to be so satisfying that it is worth it. And when I say worth it, it is worth it in terms of money also. For a YAG capsulotomy, you get 3,000 rupees, 4,000 rupees. For this, we charge 25,000 rupees. And the Mediclaim also gives it to you. This is my Gujju mind happening. And I might not want to tell you, but we have done sometimes even 3 times. There is a high myopic patient. She was also in her 40s, and now she is about 51. And we have done 3 times, and she is also very happy. Somehow she knows that she should not go for a hole in the posterior capsule. I will just try to forward it a bit. Just look at the glow on the posterior capsule. And the vision of these patients is on day one so crisp that they say that, okay, they have got their vision back. I'll tell you what, whenever you do a posterior capsulotomy with a YAG laser, there is always a chance that you might pit the lens, right? That is always there, especially in a multifocal lens, right? There is a chance that you might have some liquid in those acidic pulse, and this liquid sometimes causes inflammatory reaction in the chamber. And of course, CME and all those stuff is always there. So vis-a-vis, this is an intraocular surgery. I would advise only if you are very confident and very scrupulous in your operative SOPs, then only you perform this kind of a procedure, and only after a lot of deliberation. So I believe this is the end result of this. This was an unedited video, so I probably, no, this is an edited one. This takes about 15 to 17 minutes. And just look at the result. Right? So let me show you the pre-operative one, and this is the post-operative. Right? So this is the pre-operative, and you also the post-operative. I believe it is definitely worth it. Right? Convinced? Okay, I'll show you a few more examples and then conclude. Can I have the other one, please? How do I get the other one? Yeah, I have it here. I have it here. Okay, karna hai? VL6. Okay. Okay. Okay, so this is also another doctor in whom we did.
Towards me. No,
Here I'm
towards
trying
me.
to show you all
This
the
side.
steps. And I'll try and see, just look at this.
The light.
And from this, you can go ahead and reach here. So this is my contention, and I believe everybody should be trying to opt for this because it ultimately gives you a very satisfied patient. I'm open for any questions. Thank you.
Sir, there are lots of beginners are there. What is your tip or guidance for them to start it? Or
To start,
what the complications you face at early time of your skill
Uh,
so that we do not do this, repeat the same?
Yes. So the biggest complication is that you might tear the posterior capsule, but that is what you are ultimately going to if you have done a post-YAG capsulotomy. And the second one is that though it has never happened, but theoretically it can happen that you might dislocate the lens if you are not very gentle. But there is always the third and the most and always there is endophthalmitis or an inflammation. So these are the things which can happen in such patients. Touch wood, we have punctured the posterior capsule only once. Otherwise, no other untoward incidents in this many 10 years, 11 years.
Lovely. Sir, how you can you do it in a toric cases?
All cases. In
So
fact,
how will
I have
address
about
it?
100 videos with me. My laptop did not work. Otherwise, I would have showed you the multifocal lenses, the toric lenses, everything can be done. We have to understand one thing, that we have a lot of backlog of patients who were operated before 10 or 12 or 15 years and who all are coming back. And at that time, we did not have that knowledge of a good posterior capsulorhexis, a good anticapsulorhexis sitting on the lens meter and all that stuff. I have a lot of array lenses. If you remember, the array were the first multifocal lenses in our country. And those patients are so happy because a lot of them had a YAG pitting on the lens. And all these patients, when they have a pitting on the lens, they actually are going to be unhappy for life. So yes, you have to weigh the pros and cons, but in my hands, this is a very regular surgery. We do it probably twice a week. Dr. Radharaman? Yes.
Yes. Do you have any difference in CME in post-YAG and post say suppose you are taking it for multiple surgery, that also increases the chances of CME in cases,
yes.
especially in cases of diabetic cases.
Yes, but especially not with the intact posterior capsule. This happens when you have a rent in the posterior capsule. This does not usually happen. In fact, we have none. None of our patients have ever got a CME or an end-off or an inflammation. Luckily, the eye is very forgiving. You may say it has already been sensitized once with the surgery and the IOL, and it does not react again.
I am particularly asking about the diabetic.
Yes, sir. All these patients, all kinds of patients. Like I said, first few years we were taking only high myopes in patients who had a history of RD in the other eye or some kind of a posterior segment complication in the other eye. And then now we have started taking, going ahead with almost all routine patients also. We give them a choice. And younger patients, definitely we go for a.
Non-dilating people also?
No, I have not done any in non-dilating people. No, I have not done that because trying to touch the iris will add up to the inflammation. Somehow it is, frankly, I've never encountered a patient with a non-dilating, so I'll have to keep an eye on it. Yes.
Well, suppose you, in any case, you are done PI, YAG laser.
Yes.
And do you think that YAG laser is creating a lot of problems, even if the lens is in place?
Initially, when we started this concept, there were a lot of literature on this, but somehow now people have understood that we have to do a very low energy, small YAG capsulotomy, and so probably it might not be. But the kind of vision these patients have, because see, they have a pinhole vision after a posterior capsulotomy. You cannot do a big posterior capsulotomy, right? Yes. If you do a big posterior capsulotomy, you're going to end up in trouble. So the vision of a pinhole vision, vision through a pinhole on the posterior capsule versus this kind of a capsule is always inferior.
No. Is there any study that is
No.
that is convincing that your process is better than the
No, not many people are doing it, and that's why there is no study.
No, is there any study that any advantage, better advantage than the YAG?
No. Like I said, not many people are doing it. I'm trying to group in more people, and then yes, please.
There is no study supporting this. If any complication will end up there.
Yes, you have to take a risk. Every surgery is a risk. But like I said, you have to be very particular in your SOPs about pre-operative sterilization, your technique, your skill, and convince the patient. And like I said, these patients, say for example a myopic patient, he or she is going to have a huge space beneath the IOL. So it becomes very easy to go and maneuver beneath the IOL. But yes, a complication is always there.
How to handle the legal issue?
No, I don't think there is any legal issue to a doctor doing any procedure, and nobody can say that this is wrong. No, criticism could be there, but nobody can say that this is a wrong procedure. There are a few surgeons doing it, but yes, we are in the minority.
But main advantage is economic.
Yes. And another thing is
that was the end of the talk then.
And another thing is what do you advise to prevent it actually more of this thing during your cataract surgery? Do you take any extra effort other than
No. I don't think. A lot of different methods were shown of irrigating the equator, having a perfect rexis, that is always there. Having a compatible material and lens design is always there. But I don't think any of these polishings and etc. mattered in the posterior capsule specification. Okay, thank you very much.
Thank you, sir, for
Thank you.
giving us an idea for
New innovation.
new innovation and technique.
New innovations.
And we have one group photograph and then invite the next session for